Fantastic. So we're going to get started tonight. Thank you, everyone, for joining the Grand Rounds. I'm very pleased. And tonight's highlight is going to be the proverb, when there is a will, there is a way. And one of our distinguished speaker today is going to singularly present to you some of the work that he's not only doing, but I think he's going to architect how creativity, innovation, difficulties, persistence, hard work, and passion all combined together. And before I go and introduce and make the suspense known, I'm going to just give some highlight to the today's format for sharing the CME credits. So this will be highlighted on the channel website. For the CME credit for today's session, this is your opportunity to text 203-852-888-816-4893. This is customary to be done within 12 hours to get a CME credit, and please text as an SMS message. And for the MOC, please complete the step 1 and have this link, which will be again shared in the chat window, and use the room code future59. If you answer the questions correctly, you will get directly your ABIM credit ID credited with the MOC points. So again, CME credit, text, and then followed by MOC point. Use the step 1 and go to the link, use the room code, and answer the questions correctly to get the MOCs. All right, so with that, I'm very excited and actually very pleased to be able to introduce Dr. Mehmet Silingiroglu. Dr. Silingiroglu was recently introduced to me. I came to know about him very recently, at a conference in Pakistan, when our common friend, Dr. Abdul Hakim, and himself, we were together as co-presenters. But more importantly, just recently, he was a reference to one of our faculty members. And when I spoke to him, I just immediately recognized that there is a tremendous talent here. And just to give a few words about him, Dr. Silingiroglu originated from Turkey, doing his internal medicine. He then came to Virginia to continue his internal medicine residency, Commonwealth University. And then followed by that, he did AHA fellowship in molecular cardiology and Methodist DBK and Baylor. And I saw Robert Roberts, who is the editor-in-chief of American Journal of Cardiology, was his mentor. No doubt that he subsequently continued to have a terrific impact on research in cardiology. He subsequently also continued to do interventional cardiology and also a fellowship in structural heart disease. And then when I was reviewing his CV, it was amazing to see. I think he may be one of the rare person who has amassed an ability to create a national consortium by working in several biomedical engineering university. I saw at least 2 or 3 biomedical engineering institute. He's currently continuing to have appointments in Turkey and Arkansas as in biomedical engineering. Simultaneously, he continues to impact several universities through his research. He was the director of translational research and interventional research in the University of Cincinnati, but subsequently he has adjunct appointments with UTHSCA at San Antonio and the University of Texas MD Anderson Cancer Center. And within this consortium, he has collaborated with numerous faculty members and not only pulled through multiple clinical trials and impactful, he's got a very impactful grant-funded history in clinical trials in cardiology, in interventional cardiology, but also besides investigator-initiated grants, he's currently a co-PI on an NIH R01 grant that is currently on and looking into a very interesting facet of interventional cardiology on lithotripsy, and it's titled Calcium Fibrous Tissue Interface Interaction in Coronary Arteries in Chronic Total Occlusion in an Animal Translational Porcine Model. He has over 180 publications. He has multiple patents, and but I think he's going to tell you some unique concepts today. And it's very intriguing that a person with an interventional structural background chose to speak on an area which is really not typically spoken by an interventional cardiologist, and that is on cardio-oncology. And I'm really excited and intrigued, not only, Mehmet, to be able to get to know you, but also thrilled that you personify so many facets of creativity and persistence and hard work that I think we need to learn from you how to go through this. Everybody complains of difficulties in life, but I think you pronounce and show through your career that any difficulty, any hardship can be overcome. It's just the persistence, passion, and I think maybe it will be very fruitful for us to have that discussion either through your presentation, or maybe you should singularly tell us how you have overcome so many challenges. So with that, I present to you Dr. Salingrelu, and we look forward to learning from you.
Thank you very much, Dr. Sengupta, and all the faculty for attending and giving your time. And I am very humbled by the introduction, generous introduction. I have been to the system, your center, a few years ago. Beautiful center, obviously one of the top universities in the nation with a lot of research. So I am really honored to be presenting today, and hopefully I can come in for one of those days and revisit with you all. Will I be able to share my screen, please, at this time?
Yes, I think you should be able to do that.
Okay.
You can try and see.
So we are going to, I don't know if you are able to see. One second.
Yeah, we are able to see. You can go to slide mode.
Not the one. I want to go to this one right now. Okay. Is it projecting all right with what I have at the moment? Okay.
Yes.
So today I'm going to talk about cardio-oncology. It's not something new, but I collaborate with a lot of universities, and I will be honored to collaborate with you and your faculty as well. I really love research. I really love clinical work, and I really love teaching and learning every day. So this is a new field established actually by three of us, by Dr. Cesar Iliescu, who is the professor of medicine and director of the cath lab at MD Anderson, world famous cancer center that happened 10 years ago. And the other one is Dr. Kostas Marmagiolis. And three of us get together, and we basically said that there is a lot of disease going on. Somebody said initially when we opened the cath lab at MD Anderson, they said, "Are you crazy? You're opening a cath lab at a cancer center." And now there is a lot of patients who have basically cardiovascular disease, and they definitely do need interventional cardiologists and cardiologists who specializes in cancer patients. A lot of patients live longer now. 1 in 150 patients do have cancer. They are cancer survivors. And basically, because of chemotherapy and radiation therapy, they develop diseases like this, as you can see in the osteal RCA right here. So presentation outline is going to be mechanisms of cardiac toxicity in cancer patients, ACS in cancer patients, special considerations in the cath lab for cancer patients, and some challenges, and how do we optimize the PCI results in these patients, special procedures in cancer patients. So in all days when I was in Houston, Texas, at Methodist Hospital. Basically, at that time, we used to put bare metal stents on these patients and basically send these patients out after placing bare metal stent and basically send them out with 4 weeks of antiplatelet therapy. The time has changed now. We basically put in these patients drug-eluting stents, no longer BMS, and I will tell you the reasons. So the number of the patients who are cancer survivors because of significant advances in the last decade in all parts of medicine is going up. Right now, there is a patient-specific or person-specific immunotherapy beside the regular chemotherapeutic agents. So instead of basically giving agents that basically toxic to the body, everywhere in the body, basically we can give specific agents that are targeted into the cancer cells, less injury to unintended injury and iatrogenic injury to non-cancer cells. So cancer survivors are living longer. And the number one killer in cancer patients is no longer the cancer itself, but indeed in the survivors is the cardiovascular diseases. So 14.5 million cancer survivors expected to increase to 20 million by 2020. This is an earlier data. So I imagine that it's probably much more than that at the moment. Cancer patients have been excluded from most PCI and randomized clinical trials, not just PCI, but non-PCI trials as well, because of the tendency for cancer patients not knowing the mortality and the mixture, unintended mixture. Different cancers have different survivals and treatments and etc. Not to mess up the studies, clinical studies that are being done. So they have been excluded. So we really need to know about these cancer patients, what happens to them once they survive the cancer. So cancer patients have basically problems with the vasculature and the heart from the cancer itself, from the chemotherapeutic agents itself, and the radiation that we will be discussing. So the vasculature is exposed to many, many injuries. But one of these is the radiation-induced vascular toxicity. And what we find out is from our research is the radiation induces oxidative stress, and it activates the NF-kappa B alpha pathway and causing into inflammation and injury in the vasculature. And therefore, you can see an osteal disease while the rest of the artery is pristine and free of any coronary artery disease or atherosclerotic disease. You can see like a napkin ring shaped left main disease or RCA disease in these patients. It is very, very unique how these patients get this fibrotic, significant narrowing that can cause sudden death, actually. There are some interventional cardiologists who spent a lot of time in the cath lab, and they also get radiation injury. We will come back to that. There are certain things that can prevent that, and instead of happening. So 50% of cancer patients do receive radiation. This is very important. And oxidative stress and inflammation, independent of atherosclerotic injury, is the common scenario. Cholesterol plaque formation and thrombosis can appear within few days. So not only that, independent of atherosclerotic process, it induces a disease through the oxidative stress, but somewhat similar, it can induce an atherosclerotic disease by initiating the initial injury on the vessel wall. But the one thing that we have seen in these patients when we have done the research and papers have been published, I am happy to share with anybody, when we have done the OCT imaging and 3D OCT imaging and visual histology OCT imaging in these patients, what we have seen, the common denominator is the fibrosis, extensive fibrosis from the oxidative stress and the injury from the radiation. So radiation-induced coronary toxicities, as you can see, it can be left main disease, osteal disease usually. It doesn't occur in the body usually, it is in the ostium. And the reason that That's where most of the radiation comes in, and it depends on if it is a breast cancer patient, for example. If it is on the left-sided radiation versus the right-sided radiation, it can affect the coronary, specific coronary artery. And extensive mental radiation like Hodgkin's lymphoma or esophageal cancer leading to ostial or multivessel stenosis, but most of the time they are ostial. 10 years after radiation therapy for Hodgkin's, severe stenosis of the left main or RCA ostium has been seen in post-mortem studies in 30% of patients without having any symptoms whatsoever. Focal radiation has been chosen to reduce the amount of radiation, iatrogenic radiation unintended into the vasculature. So focal disease in the mid LAD and LAT can be seen with the left breast radiation, proximal more on the right side, because the right side sees when you give the radiation to proximal RCA. Well, you just said that they usually doesn't happen in the mid body. It doesn't happen in the mid body or the distal unless most of the radiation is occurred in that part of the coronary artery. So statins have a lot of benefits. So what about using the statins prior to radiation and putting these patients on statins? Because as we know, statins are effective in the NF-kappa B pathway, and how we can reduce the oxygen species radicals, oxygen radicals, and then relatively reduce the amount of radiation injury on the vasculature. Is it possible? The answer is yes. Studies have shown that the amount of the myocardial injury, contractile dysfunction, and possibility of heart failure goes significantly down because your superoxide free oxygen radicals goes down with the use of the statins. And statins have also been shown to reduce cardiomyopathy that is associated with adriamycin. It is a recent publication. I didn't have a chance to put it there. This was one of our publications that we have published that shows basically the vascular toxicities of the chemotherapeutic agents in all the vasculature. You name it, from the peripheral arterial disease to stroke, from myocardial inflammation to vasospasm and pulmonary hypertension. So we want to identify them and we want to basically prevent them as early as possible. And I give you an example. These are some of the agents that we have listed, and they have been found because we have an extensive database at MD Anderson Cancer Center in regards to the patient's database. We have millions of database, so we use artificial intelligence and to look at the analysis of very detailed analysis of these chemotherapeutic agents and their associations for possible adverse effects in the cancer survival, such as 5-fluorouracil that we use can cause angiospasm. The patient can comes in, they have Takotsubo cardiomyopathy, but it's not only from the stress of the patient from the cancer, but it's at the same time the 5-fluorouracil causes vasospasm, maybe prolonged vasospasm leading into myocardium hibernation. So that kind of things that we see. With cisplatin, again, very well known to cause vasospasm. The patient comes in with chest pain, they have completed the chemotherapy, they may have a little bit of leak of their high sensitivity troponin. You do an angiogram on them thinking that it's non-STEMI, and you find out that it's not truly a non-STEMI, but it's a type 2 myocardial infarction, basically the demand kind of ischemia from prolonged vasospasm. You can clearly see that how many of the agents can cause Takotsubo cardiomyopathy, vasospasm, and angina pectoris. So it's very, very important to understand that. Now, in chemotherapeutic agents, the vasospasm is there are multiple different etiologies that how they do different pathways, what I mean. For example, for 5-fluorouracil, it's vasoreactivity. It's actually one of the board questions for the cardiology. Severe vasospasm, paclitaxel, and docetaxel, kind of thing. So we have a big list of agents that can cause, for example, cisplatin can cause, because of prolonged coronary spasm, it can cause coronary thrombosis in multiple territories. So you really, really need to understand that. Bleomycin, for example, can cause endothelial dysfunction on the long run. And does this endothelial dysfunction is really important? Is it temporary? Is it permanent? Does the endothelial dysfunction causes an atherosclerotic process to begin in a patient who otherwise have been healthy, young, and prinzmetal angina? This is typical. This is a board question as well. Cyclophosphamide that we use for bladder cancer can cause prinzmetal angina, that patient may come with chest pain, and you do coronary angiography and their coronaries are wide open. They don't have an underlying CAD, but if you do other studies, microvascular, etc., you may find out to be positive. And accelerated atherosclerosis, right? So if basically patient has, all of us have plaque, but progression of plaque can be initiated by some chemotherapeutic agents, and the patient can get an earlier CAD rather than later. Takotsubo cardiomyopathy is not just stress, but also can happen from chemotherapeutic agents itself. So we need to know that. What happens when they develop Takotsubo cardiomyopathy? It is the same prognosis as the original, or I should say the idiopathic, if you want to say that, Takotsubo cardiomyopathy or de novo, or is the chemotherapeutic induced Takotsubo cardiomyopathy is more irreversible? We don't know. The studies are going on that, looking at it, outcomes with using artificial intelligence and augmented analysis. Cancers, so cancer effects requiring PCI, spontaneous coronary thrombosis, we just said it in cisplatin and cyclophosphamide. Malignant coronary embolism, myxomas can cause little bit of particles of myxoma can go to coronary arteries and cause it to have embolism. And you may see a distal vessel, very distal, there is filling defect, but indeed the artery is pristine. External coronary compression from the left atrium, lymphoma or thymoma, or invasion of coronaries by angiosarcoma. So at Methodist, there is a world-renowned surgeon, Michael Reardon, who basically takes the angiosarcoma and puts the heart together again. And some of them can be done, some of them cannot be done, but there is series I recommend for you to read at them. ACS in cancer patients, they're different ball game. It's not same as the ACS in all regular patients. They have a lot of issues, but one of which is the thrombocytopenia. And if you look at them, if you look at the cancer patients, usually we have this impression, wrong impression that they are cancer patients, so they are not going to have a normal lifespan. So do you really need to do PCI on them? Do you need to put drug-eluting stent in them? Or do you need to do medical therapy and just get away with them? The answer is that if you treat their coronary artery disease, they have a pretty good survival if they are a cancer survivor, especially, and if their prognosis of their cancer is normal. They go into almost a normal lifespan. So it is very, very important. Silent ACS in cancer patients, so because of the chemotherapy that they're taking and radiation, they may not have the sensitivity. They may not have the nociceptors as the normal human beings to be able to tell they have chest pain, they have angina, because radiation also injures the nerve endings as well as the chemotherapy. So they may not necessarily have per se painful chest pain, shortness of breath, and they may present with atypical symptoms. Medical therapy, when you look at the patients with ST elevation versus not ST elevation, is seen 1 year survival is 26% if you don't do anything and leave them with medical therapy. We really need to do catheter-based therapy on these patients because, again, cancer survivors don't die from the cancer. They die from the coronary artery disease because of the combined effect of the chemotherapy and radiation. So we really need to take an aggressive, when I say aggressive, I don't mean the treat unnecessary lesions, but we really need to provide them the same level of care for ACS as we do for the non-cancer patients. Retrospective original studies on the Duke between 1996 and 2010, we have now bigger databases on this. We publish usually around 15 to 20 papers about cardio-oncology every year on our patient outcomes. We have like 100 million patient outcomes data available to us. And they have looked at 22,277 patients, and specific group, they dissected the patients with the cancer. If you look at the cancer patients versus the control group, if you provide them the same level of care for their ACS and coronary artery disease, they have similar survival as long as they are cancer-free from their primary cancer. So please remember, more than 60% of the patients with ACS, cancer patients, are silent. The patient may come to you, I have fatigue. I am not feeling good, not after chemotherapy, but after 6 months after chemotherapy. They have a little bit shortness of breath. They're feeling dizzy. You may need to think about they may have underlying coronary artery disease because they had an insult from combined double insult from the chemotherapy and radiation. Please think about that. Medical therapy alone yields 1-year mortality of 74%. So if somebody has left main disease, their 10-year survival is around 30%. Okay, so you have to treat it. This is similar to that. So for both STEMI and non-STEMI, primary PCI for cancer patients for STEMI results in twofold increase in mortality. So we really have to treat these patients. We really need to find and diagnose early coronary artery disease in these patients. Patients with recently diagnosed cancer, less than 6 months, are at a higher risk because they are getting double jeopardy. Data about non-emergent PCI in cancer patients are disparate. It was disparate. It was not much available, but now it is available. We publish a lot of data. And this is the first paper, ever paper that was published, and it was endorsed by the American Society of Coronary Angiography and Interventions. Basically, we say it's SCI, and with other societies as well. And it is a very detailed paper. We are trying to update that because a lot of data came in since then. So the number one thing we see in these cancer patients is thrombocytopenia because of chemotherapy and radiation. It also causes bone marrow to dry up. So basically, can we do safely in these patients who have a thrombocyte count of less than 30,000? The answer is absolutely yes. And we learned that. We are no longer scared to do a heart cath as specialists of cardio-oncologists who have a platelet count of 5,000. And do it safely, radial access, really be very careful, evaluate the lesions very carefully using FFR and OCT. We use OCT in every single patient to make sure that we don't do intervention on a patient who doesn't need intervention. We basically, if we need to stop the antiplatelet agent in these patients early, we do OCT. We make sure that stent is covered nicely, and we go ahead and stop, and we say, okay, you need to do mastectomy, fine. You want to do this, fine. So we use the OCT very diligently. And there is not a low platelet threshold for coronary angiogram. We do it safely. It expected year is less than 1 year. 1 year. PCI only be done for STEMI and high-risk non-STEMI patients. With chemotherapy, dual antiplatelet therapy may need to be extended due to delayed endothelialization of the stent. That's why we are using absolutely the OCT imaging. It gives us very detailed, nice view. We do, if we need to do, we primarily do radial. And if we need to do femoral, we absolutely do very meticulous access, as you can see, micropuncture technique. And we only place the sheet if we are above the bifurcation below the inferior epigastric artery. And we usually manage these patients with try not to put closure device because these are cancer patients. If it is in the immediate arena, they are kind of immunosuppressed. We don't want any infection. But 99% of the time, we do radial access on these patients. And multiple radial procedures or A-lines, dialysis, they may need the radial artery. We make sure that they don't need these things. So we try to be very careful with that. If they had contraindication to radial, then we do the femoral, but we do it very carefully. Do we use the closure devices if they have very low thrombocyte count? As long as I know that we are not high stick or low stick, we can do that. We probably use the extravascular closure devices not to leave anything inside the vessel. So aspirin we use only when the platelet count is more than 10,000. That is fine. Dual antiplatelet therapy when the platelet count is more than 30,000. These are board questions. They may ask that to you. So these are now common knowledge, and cardio-oncology now is a established subspecialty, and many centers do have cardio-oncology, and many centers do have cardio-oncology fellowship after cardiology. So we use the heparin. If we use unfractionated heparin. Why? Because we can reverse it. We use 30 to 50 units per K. Make sure that ACT is in the range, maybe a little bit on the lower range, 200 to 250. And in patients who have basic platelet count less than 50,000, we recommend against the use of Procedural, ticagrelor, because in thrombocytopenic patients, we may not be able to control the bleeding otherwise, and 2B3As only if they have a lot of clot burden after you have done the thrombectomy on these patients for the vessel if you needed to remove the thrombus. So we do have the need for premature DAPT discontinuation in this patient because of procedures. In that case, we basically go ahead and do OCT, make sure that their stents are well apposed, there is no malapposition, and then we can do that very safely. In patients with evaluation of patients with severe anemia and thrombocytopenia, novel mechanisms of ACS. So novel mechanisms of ACS basically is prolonged spasm, and the toxicity from radiation and chemotherapy creates this hypercoagulable state. So please make sure that you don't use bare metal stents in these patients, and treating restenosis is much harder than treating a lesion de novo with drug-eluting stent. It is now very well established. In patients with cancer, we have to use the drug-eluting stents. No question about that. There may be very few exceptions, but DES is the way to go. If the patients are not preloaded, we may be able to use Cangrelor to get the anticoagulation on board, antiplatelet agents on board right away, and then we can load them. So this is basically a Protect OC registry. We were able to, we use in every single patient at MD Anderson. When we do intervention, evaluate the patient, every single patient gets evaluated with FFR if they need to, unless it's a 90% stenosis, because we don't want to put a stent in a patient who doesn't need it. Number two, if we do need to discontinue, first of all, we want to make sure it's a well-apposed stent, and after, so that we can give them the minimal duration of antiplatelet therapy, dual antiplatelet therapy. And if we need to discontinue, we make sure they will have a major surgery. We make sure that they are, if they had just in the last 3 months or so, we make sure they have OCT. We have a great coverage, and then we can hold on their dual antiplatelet therapy. You can see that. And the challenges that we have is the OCT for all patients who need to stop the DAPT. The answer is no. If it is only in the near past, what is the preferred bridging agents? Please, I beg you, don't use heparin thinking that heparin is going to work on a stent that is freshly placed. I have seen patients who have stent thrombosis in their carotid artery that was freshly placed and patient needed CABG. Please, if you need to bridge these patients, use 2B3A instead of using just heparin or low molecular weight heparin. One is antithrombotic, the other was antiplatelet. So for stents, we need the antiplatelet. Novel mechanisms for the ACS, we have discussed that already. Again, we feel very comfortable doing a CAT on a patient with thrombocyte count of 8,000, 4,000, and believe me or not, you have enough in their system that they can get hemostasis achieved, and we have agents that we may be able to use for hemostasis achieved. For example, we use the potassium citrate for the radial access so that our TR band time is much less, and we use the hemostasis pulse oximeter saturation to make sure they don't have radial artery occlusion. Most cancer patients become thrombocytic during the therapy, as we have said. This is the data set that we have also published. And the safety of the diagnostic and therapeutic cardiac cancer patients, I don't want to go to detail, but the bottom line is that there is truly not a platelet count that we will not be doing coronary angiogram. That doesn't mean we do it in everybody. We evaluate the whole patient. We talk to the oncologist if there is true indication, and only after that, we basically take the patient to the cath lab if their ischemic score or Jeopardy score seems to be high, right? We do a non-invasive study. If their ischemic load ischemic region is 15%, despite medical therapy, they have symptom. Yes, we proceed with coronary angiogram, but not somebody who has a 5% perfusion defect, reversible perfusion defect, and doing well on medical therapy, etc. So remember the numbers. Aspirin, more than 10,000, and dual antiplatelet therapy, more than 30,000. Those are very, very important. And this comes in very important. Should we basically transfuse the patients with the platelet therapy? The answer is no. Please don't transfuse the patients for platelet. We don't do that. They will go and stick into the new stent, and they will cause acute stent thrombosis. We rather you not to intervene on that patient. So please don't transfuse the patients with the platelets, and there are other reasons too. You want to make sure they are irradiated and etc. These are a lot of case reports and everything you can see for patients who have acute coronary syndromes, coronary embolization with advanced breast cancer, coronary embolization from myxoma, and there is a lot of etiologies can happen in patients with ACS. It's not just atherosclerotic process or other things. How many STEMIs in cancer patients are due to malignant neoplasm? Those are the questions. Should aspiration thrombectomy be used more often? The answer is yes. And even though the aspiration thrombectomy is class 3 right now, yeah, I just recently took my interventional boards and I passed, thankfully, by ABIM. And there were a lot of questions about thrombectomy. If you have a large thrombus burden, you have to do thrombectomy, especially if the patient has been having chest pain for the last 2-3 days. But you have to do it very carefully, not to pull the clot out of the coronary and let the clot go to north to the brain. So that is very, very important. And you should send the debris, if you get a debris, for pathological examination, because it may not be just clot. You may just think that it is clot. Stent-induced cardiomyopathy, we have also published that. 10% of the cancer patients with ACS, coronary hyperreactivity we look at, endothelial dysfunction and spasm are the potential causes. FFR is recommended. We don't want to put stents in patients who basically does not need stents, especially in cancer patients. And we want to make sure we use imaging, either IVUS. I love OCT. I am the OCT guy. You can clearly see stent malapposition. So if you discontinue the antiplatelet agent in this patient, you will have clot. Please don't do that. And POBA in patients less than 30,000 platelet count may need basically POBA, or you can basically do in this patient's surgery. And BMS, when platelet count is more than 30,000, needing elective surgery, I tell you that instead of that, if that elective surgery can wait, I'd rather put a DES on this patient and basically do the surgery a little bit later, if it is a knee surgery or not emergency, instead of basically putting this patient on bare metal stent. Third generation DES for all the rest, it says. Well, I basically disagree. Only a few patients needs to get the BMS. OCT and IVUS is recommended to assure all stent apposition and absence of complications. And BMS is improved, yes. The stent restenosis rate is around 5% or to 10% at the most. But again, I rather do the drug-eluting stent because there are other reasons why there will be restenosis. Special procedures, we do the patients, if they need a right heart cath, we don't stick the groin necessarily. We go ahead and stick their antecubital region, and you can do everything from there. And unexplained dyspnea, fatigue, hypotension, we want to measure their pressures. And remember, board questions, and for the residents and fellows, restrictive, constrictive physiology will be in your boards. So make sure that you understand about the correspondence and non-correspondence between the LV and RV. So if you have constrictive cardiomyopathy, you are going to have pressure changes because the septum is going to shift, and you will have drop in one ventricle versus increase in the other ventricular pressure. So you need to know in a patient who comes in 10 years after radiation for Hodgkin's lymphoma, they have shortness of breath, the liver is palpable, they have basically edema and JVD, you may need to consider constrictive pericarditis. And valvular dysfunction, these patients can have mitral annular calcification, even aortic at times. We use the 5 French sheet. Sometimes I use the multi-purpose diagnostic catheter. So you can take biopsy at times and look at what is going on. If it is in the heart, now we have a lot of things you can remove. You can remove suction devices, a lot of messes in the tricuspid valve, including treating endocarditis. We have cases like that in cancer patients. So if you have anthracycline-induced cardiomyopathy, remember, statins seems to be reducing that. Then you may need the tissue biopsy. But first thing we look at is in the echocardiogram, for those of you, is the LV strain. So is there any way that we can establish an AI program that we will be able to look at the LV strain becoming abnormal much earlier than before a patient that I'm going to show you, a real patient that is going to have LV dysfunction? And very rarely in this patient's fulminant myocarditis. Pericardiocentesis, you need to know that. You need to be an expert. We use micropuncture needle. We use special configuration and under the echocardiographic guidance. But please try not to get necessarily these patients and say, hey, you need a pericardial window, let's get it done. If the patient needs emergency pericardiocentesis, you do micropuncture access technique. It's published in JACC. It was our paper, and then basically put the drainage catheter and then go from that. But you need to be able to do these things and keep the drain for 3 days. But of course, if draining less than 75, 50 cc's, every patient is different. But remember that if it is cancer related, it may come back. And we have also published this paper. I think it was JACC. So the patients who have recurrent pericarditis, we basically go ahead and do catheter-based approaches for these patients, and not surprising, most of them is the malignant cells. Now comes into BAV and the TAVR. If the patient is surviving more than 1 year, yes, we do structural heart. Can I change and finish my talk with one thing here? And you guys tell me, please, if you guys can see that, please. Okay. So I'm going to switch the video sharing. So I come here. I am almost done. Give me a second. So in US alone, 14 million, we went through that. So let me give you a patient. This is a professor. This is an actual patient who has basically 2 cancers, has a severe aortic stenosis. We go ahead and evaluate the patient. And then this is a microclip patient. This is a breast cancer patient. She has taken the chemotherapy, letrozole, LV dysfunction. Unfortunately, she has not been screened with LV strain. So her ejection fraction is severely reduced. Let me go here. And then the surgeon doesn't want to touch her because she is high risk. And if you fix the mitral valve, she may not do well. So we went and did, you can see the MR. We use a 3D, and I do my own TEs. We put the clip where at exactly the ejection point, and then we evaluate it. Usually, sometimes the gradient is high, but when you eliminate the MR jet, your gradient goes back to normal. You can appreciate the amount of reduction in the MR jet. I was going to show you a TAVR patient, but let me tell you that patient had a urinary cancer, bladder cancer, at the same time had a colon cancer, had ileostomy tube and the urinal tube, and we were able to do on that patient the TAVR as well. And with that, I'm going to stop so that we can give you a chance to ask some questions. And I thank you all very, very much.
Thank you very much, Mehmet, for this very, very great presentation. It's a complex topic, and I think you had several polls during this presentation. So I think our trainees will really appreciate for spending some time and going through some of the details.
Absolutely.
We'll also invite now Dr. Michael Wong, who's director of CCU, and also he is an interventional cardiologist, to join me for the panel. But I want to start off. I want you to just tell us a little bit about how you have stayed so focused clinically, and how you have balanced it with so much of research that you're doing. And the topic that you presented today is very clinical, but I know that you're doing a lot of work in research. How have you been able to accomplish so much of different tasks while people always have difficulties in finding the balance. So how did you get the balance right?
Yeah, thank you. That was an amazing question. So I was very privileged to work with the best of the best in United States of America. I love this country. This country has a lot to give to people like us, all of us, like you and me. And when people start whining, and I'm sorry to say that, and they complain about this and that, I just tell them, look, we are in the best place. There is no country on the face of earth that spends $40 billion as NIH, just the NIH itself, on research. So number one, to be efficient in your time. So I do a lot of clinical work. Don't get me wrong. I'm still up to date, and I do a lot of cutting edge clinical work as of today. But I was able to save some of my time and managing my time during the day to be able to collaborate with different institutions. And I have been around, if you want to say that, the molecular cardiology and the AHA Molecular Cardiology Fellowship helped me a lot. I learned there a lot from Dr. Robert Roberts in Houston, Texas. I learned a lot from Dr. Christy Ballantyne. I learned a lot from Dr. Zagby, Dr. Quinones, Dr. Al Reisner, Dr. Neil Kleiman. So I had a lot of good mentors. How I was able to see in real life how they do research, how a high quality research they do, and how they initiate the new question and go from plan A to from A to B, meaning the question, what can we solve? How do you collaborate? And you don't have to be necessarily physically present in that institution, but you are able to collaborate very well in regards to grant application, publication, and research. And at the same time, managing your day, the time of the day, managing it efficiently so that you have time for these research activities. Otherwise, nobody is going to give you, if you are even full-time, I'm part-time, but even if you are full-time, you will not be able to find the time to dedicate. The other thing is that what I have seen, Dr. Sengupta, is basically if there are more than one people collaborating, it's everybody's time. You already reviewed the paper, you already brainstormed the hypothesis, and when people get together in the same field with biomedical engineers too, it is an amazing harmony how the unnecessary questions get filtered and you become focused on the main project.
So, but let me ask you, Mehmet, so you don't feel burnt out? Because you're an interventionist, you do TAVRs, you're doing clips, you're doing research, you don't feel burnt out?
I am going to answer that question in layman term. For me, I believe that the Lord has created us to serve mankind. There is nothing makes me happier than a true research that will have application on mankind. And also there is nothing makes me happier than seeing a patient treated, greeted, treated like a family and going home. So you really have to love this. It's a lot of time. So if it is somebody who wants to make money instead of with their time and who says, I'm going to do research, but I want money, I want money to somebody to pay me to do research, that's not the right thing that's not the right place for me. For me, I want to dedicate my life to humanity, and I really do. And I enjoy both providing the clinical work as well as trying to bring something new to the field. For example, our CTO device, OCT guided CTO device, will eliminate the need for antegrade, retrograde, a lot of radiation, angiography, potential for CTO risk, mortality 10%, procedural, etc., so that we can basically see and go through the occlusion as we are doing the case. So that is like mind blowing. It makes me happy, gives me more energy.
Great, Mike.
But some people think I'm crazy.
I think I want to. Your points are very well taken. The reason I'm saying is I'm asking you this pointed questions is because, look, I mean, currently we have going through difficult times, and where a lot of people are talking about the burnouts and the loads, particularly after the COVID. So
Very well said.
but I see you, a person like you, seems like you are happy, and seems like
I am very
you
happy.
do your work well. So the
Thank
spirit
you.
and the what do we need to learn to be happy in the work we do? Because look, I mean, money, funding, I mean, I'm sure that you have got the funding, but it's not easy. Like these are
It's not
tough.
easy at all.
Yes, but you still seem to be enjoying
So I
it.
tell
So
you, I tell you something. Yes, I am enjoying it. It's a lot of hours, days and nights and weekends. But I tell you that I believe every day I need to do something related to, not, I don't want to say work. I don't see it as a work. Related to the mission, I want to do something. Otherwise, I feel kind of guilty. But I tell you what, when we submitted the NIH grant for lithotripsy device, they said that we all have been getting NIH grants for this particular thing and OCT and stuff from MIT and Harvard. We have never had anyone from California. So they granted our funding. And it's not necessarily given, and they may revise it, they may ask you revisions, they may ask you these and stuff, but you really have to love it. So for young generations, for the next generation of cardiologists and scientists, my advice to them, and I love to mentor, by the way, my advice to them, love it, love it. The money will come. Physicians make top 1% of income in United States, more than any other country, and etc. So be happy and make sure that you find the happiness. I give you one last example. Today I had a patient who came in with chest pain, wonderful lady, amazing lady, and troponin is like 1.5. And then I asked her, I said, a lot of stress. She started crying. I said, what happened? Her son is in prison. She has not seen for a while. I didn't ask why. And then her other son has been killed by gun by one of his best friends. So I prayed with her. And I'm going to tell you this, we all thank the Lord for what we have, and we should pray for others. So we need to learn in day, yes, we have difficulties, each of us, hard work, and we want to be acknowledged. But at the same time, we should realize what we have, family, friends, science, ability to do research. In my country, in Turkey, you cannot do research. There is no funding. It doesn't matter how smart you are. But in the United States, we do. You have seen how many investigator-initiated grants I received. And I'm not, I mean, I enjoy this. I love it. So you have to love it. You have to love it.
Great. Mike, back to you for some practical questions, maybe. Or
yeah, no, this is a great timing for this talk. I was just talking to Dr. Ting in clinic today about cancer patients. A lot of us, cardiologists, are just uncomfortable because these are some of the most complex patients, and they really trust you because they're really sick. Just two quick questions. I've been doing interventional for 12, 13 years. Now I've noticed some of these medications drive up the cholesterol like I've never seen, especially like Jakafi, for some of these GVHD patients. Have you experienced using PCSK9 inhibitors for this? Is there any data?
Yes.
Probably not on this.
Yes, absolutely. So we monitor, we have a comprehensive center. So we basically monitor their lipid panels very, very carefully. And then if they need, we go. I think the Christy Ballantyne is the expert. Dr. Antonio Goto is the expert. And the main thing is that now people switch into combination therapy much earlier than trying to maximize one agent and go with that. But some of these cancer patients have significantly higher elevated, so it is not just the statin, but statin plus PCSK9. And I visited Dr. Julio Palmaz 3 months ago in Napa Valley, the inventor of the stents. So I told him, what is the next? You are the inventor of the stents, millions of stents being put. What is the next thing that you see big? He told me, Mehmet, every 6 months getting, tell me the siRNA inhibitor for the cholesterol, inclisiran or something like that. Every 6 months you can get injection in our drug therapy, where we give the immunotherapy medications, outpatient pumps and stuff. So that's where we basically go ahead and give them every 6 months cholesterol reducing agent and combine it with the statin. They reduce anywhere between 60%, close by the 60% range. So I think the answer for cholesterol management right now is to take it combined, switch to combined therapy early and achieve the goal. And this is my own personal opinion. I am a transplant patient. I take a lot of medications. I have been taking statin since 30 years old. And when I had my kidney transplant before, I didn't have angiogram. The treadmill, I did very well, 15 MET, and I have 0 calcium score. So I think we need to prevent the plaque before it forms.
Yeah.
But by no means I suggest others should do that.
Yeah. And the last question I have is, we talk about PCI, but what about cabbage? Do these patients do well with cabbage, with the lima and radiation?
So very well said. Absolutely not. We had some patients have been referred to us with non-healing wounds, and basically in these patients we do TAVR if they need valve replacement early, even younger patients. Especially now we have the low risk TAVR data, and we try to do on them image guided PCI. So last thing that I'm going to say is that please and please, people compare PCI versus cabbage with no imaging guidance. I bet you anything, if you do image-guided PCI, compare it with cabbage, you probably will not see much difference in between reintervention and mortality, because image-guided PCI reduces 40% mortality. The cabbage's only benefit is lima to LAD. So the rest of them shuts down later on. So I think if we can do PCI guided, image guided PCI, compare it with cabbage, I think the difference will narrow, maybe even better for PCI with reduced risk of stroke. Anyway,
fantastic.
I would love to come and visit you one day and soon. And I will love to collaborate with your distinguished medical center, especially Masoud is coming there, Dr. Lisa too. And I will love to work with your AI and serve the mankind in decades to come. God bless you all, and thank you.
Thank you very much, Mehmet and Mike. Thank you all.
Bye-bye.
Bye-bye.
Bye-bye. Bye.
Bye.